Hello, everyone. Thank you for joining us today. My name is Scott Olitsky, and I'm a product specialist at Orfit, as well as a licensed radiation therapist also. I'd like to welcome you to today's clinical education session about new applications for immobilization masks with SBRT treatments. Today's speaker will be Mike Tallhamer. Mike is the Chief of Radiation Physics at AdventHealth. He's going to review some of the setup challenges typically faced during SBRT setups and treatment, and then briefly describe a specialized technique that uses a thermoplastic mask for compression. Obviously, the goal with the compression setup is to limit the respiratory motion and then achieve a setup that is also reproducible on the treatment side for both the internal and external anatomy. So he'll discuss the development of this technique, highlight its benefits, and then of course explain the setup itself.
All right, thank you. My name is Mike Tallhamer. I am the Chief Physicist for AdventHealth's Rocky Mountain region. And I've been asked to share just a quick overview of a new application of a mobilization mask for SBRT as it relates specifically to a compression masking technique that we've developed for respiratory motion management. Before we get into the talk, I don't have any disclosures for this talk. I'd just like to thank Orfit for inviting myself and my team to present today. And I believe we have some objectives that need to be displayed for your CampEP or ASRT credits. So we'll do this. We'll be describing a specialized immobilization using a compression mask to limit respiratory motion. Recognize how specialized immobilization will achieve more consistent internal and external positioning, and discuss how to set up an immobilization mask for SBRT. With that being said, before we get into the meat of the talk, I'm going to just describe a little bit about AdventHealth's philosophy in radiation oncology as it pertains to us here in Colorado, where I'm today. It helps you kind of better understand why we do what we do and why things end up the way we kind of decide these procedures need to happen within our clinics. If you know kind of what we're treating with, what our technology footprint looks like, and so forth. And so AdventHealth is a very large organization, 52 campuses, 9 states. I think at this point in time, we're a little over 11,000 licensed beds. And I am the Chief Physicist of the Rocky Mountain region, and I'm based over here on the left side of the screen in the beautiful state of Colorado. And so in Colorado, we have 5 hospitals. We have 3 radiation oncology centers, 4 LINACs, which are 3 true beams and a Halcyon ring-based gantry system. We do have a ZapX gyroscopic radiosurgery system. At one of our facilities, we have 2 HDR units, and we operate completely within a single integrated Varian ARIA and Eclipse environment. That environment pushes back to our national EPIC EHR, which is the EHR for all of our hospitals. And unique to us within Advent and within the state of Colorado is we are completely dependent, I shouldn't say dependent, we have decided our standard of care within radiation oncology is to use SGRT systems. And so we are basically 100% dependent on our SGRT systems in a way that it's our primary setup tool as well as our primary motion management tool. And so we have 3 Align RT advanced systems, 3 Sim RT systems, which we'll see a little bit in this talk about CT simulation, an Align RT inbore system, which is the Halcyon SGRT system, a Dose RT system, which is the Trankoff imaging system that allows us to visualize the dose on our patients as it's being delivered live. And then a MapRT collision mapping system, which is, you'll see a little bit of it as well in this talk as it relates to SBRT planning. And so our ecosystem within the AdventHealth Colorado region kind of dictates how we approach delivery on our patients. And so with that, the treatments at our facilities use SGRT and the Orfit AIO solution exclusively across all body sites. So if you look here on the right-hand side, that is the Orfit AIO solution. It's a single base plate with indexing knee cushions. And then the cushions are basically color-coded. And so the way I refer to it with my therapist is it's largely Legos for adults. We're putting together a semi-custom immobilization for every single patient. We're currently looking at implementing the extremity system, which you would see in the middle on the left-hand side of the screen, which is more for our osteoarthritis program that we're developing. But we treat everything from palliative bone mets, osteoarthritis, all the way up to frameless, trigeminal neuralgia, acoustics, breath hold and non-breath hold SBRT, all kinds of different indications. But we are largely on the AIO solution. When I say largely, 100% of our patients are currently on AIO. The Orfit does make a SBRT specific solution that looks very much like the AIO solution. We have just, over the last course of 15 years of using AIO, we have adapted everything to the AIO solution. So with that being said, when I say things like this inside of my talks, most people, the first thing I get is, what about electrons? And what about this? And what about that? The answer in AdventHealth Colorado is always yes. When it comes to SGRT and the AIO solution, it's always yes. It is 100% yes all the time. And so hopefully that is clear. The way we drive our programs is standardized on these technologies and these immobilization systems. So with that being said, the goal for today's talk, we're going to basically review respiratory motion management in radiation oncology, because we need to understand, at least at a basic level, the problem we're trying to solve. We're going to look at some of the abdominal compression methods that are out there when considering some of the challenges in respiratory motion management. And then we're going to introduce this compression masking technique that we've developed here in Colorado. Over the last probably 10 to 12 years of using the AIO solution, we've adapted different solutions to fit on the AIO system and some of the intricacies that it offers us for different types of body sites. And then we're going to discuss how this technique addresses some of the challenges that we've already identified. And hopefully along the way, I'll acknowledge as challenges come up that we're talking about that may be specific to us because of our philosophy and using SGRT exclusively and not using tattoos and those types of things. I'll try to highlight those as we go along. That way, if it's something that doesn't pertain to you, you don't use SGRT, or you're not looking at implementing, tattoo-less treatments or anything like that, maybe that's not a concern for you. We want to keep basically the focus on the technique of the compression masking system. And so I'll try to kind of alleviate ancillary things as we go through. And then we'll look at the workflow of fabricating these abdominal compression masks by going through a CT simulation case that was actually a case here where I'm sitting today about 2.5 weeks ago. And so we'll use that as a way to highlight the way to actually build the mask and then see the result of what that mask gives you, both in the treatment planning images as well as the treatment delivery images. And then hopefully at the end, we'll leave some time for insights and answer some questions around the approach or anything else you guys might have as we go through. Hopefully I don't muddy the waters with too many other ideas. So let's get into it. The respiratory motion management, a quick review. Most everybody on this webinar is going to understand motion management. If you're an older fellow like myself, who's been in the field for about 20 years, the respiratory motion management was really coming as a proof of concept when I was a resident in the 2001, 2002 timeframe. The proofs of concept of the technologies were really published by like Ford and Lowe in the early 2000s, I think 2002, 2003 timeframe. And then being medical physicists, we don't want to be Johnny on the spot. We had to wait till 2006, and we actually came up with a task group that addressed some of these motion management issues with respiratory motion with task group 76 in 2006. And in that task group report, we addressed 4 kind of ways of managing respiratory motion: motion encompassing methods, respiratory gating techniques, deep inspiration or deep expiration breath hold techniques, and then these forced shallow breathing methods. And this is where compression kind of falls within those 4 categories. We're talking about just straight up compression with standard CT, compression with 4D CT, or compression with what we would call back in the day slow CT was actually just CT. We had single, 2-slice, I think 4-slice were all the rage when I was in residency, so that's dating myself. Now we have 16, 64, 256, we have a million slices to deal with. And so CTs are very quick. And so the idea of compression with slow CT is kind of gone by the wayside because CTs are really not that slow. But if you want a good overview of kind of the challenges and how the idea of 4D CT and motion management for respiratory motion has kind of come along in the last 20 years, at least in the time of my career, there's a great publication in the Journal of Applied Medical Physics down here on the right that came out in 2023. And it's a great counterpoint where people just kind of discuss why 4D CT is long overdue for improvement. Has it evolved since it came in? The spoiler alert, it hasn't really changed a whole lot. And so it kind of gives you a broad overview of where we were, where we're at, and kind of gives you a good overview of this. But that's essentially the problem we're trying to solve: respiratory motion management with these compression techniques. So why do we use compression techniques for respiratory management and not just straight 4D CT? Techniques like abdominal compression can reduce diaphragmatic motion to minimize tumor movement. That's ultimately the end goal here. If we can reduce the amount of movement the tumor has, we have a lot less uncertainty in the envelope of the known positions for our targets. So when we're using encompassing methods like ITV to PTV expansions for our targets, abdominal compression can reduce the amount of healthy tissue that is included in those targets. And when we're talking about SBRT, where we're dealing delivering very high ablative doses, we want as little healthy tissue in the prescription isodose line as we can maintain, and also maintain a very high degree of certainty of where our target is. Abdominal compression also comes with some ancillary or side benefits that come along with it. Abdominal compression can artificially increase the breaths per minute, or the BPM, if you've heard that during CT simulation. Most techniques today on modern CTs with 4D CT have a lower end compensation around 10 breaths per minute, because our CTs are so quick. And we're trying to sample a full breath cycle at each point along the traversal into the CT. So if a patient's breathing too slow, you may move out of one breath cycle too quickly and get into the next breath cycle. And what that does is it creates artifact like what we see in these images at the top of the screen here. We can see that there's artifact at the top of the diaphragm on the left. We see that same type of artifact, or we call it a hat artifact here, but it's largely a motion artifact. We're capturing that CT in multiple different positions as we go through the data cube and reconstruct it. And you can imagine if you have a lung tumor that's in the lower portion of the lung and that artifact happens, you've obliterated any information about that lung tumor. The same thing can be true as if you have a tumor in the upper portion of the dome, or the superior portion of the dome of the liver, and you get this artifact. You may have artificially increased the size of it, or you might have artificially decreased the size of it. So you have to be very careful about what 4D CT information is telling you, knowing the limitations of your systems. And these abdominal compression methods help get these patients who breathe relatively slowly into a more appropriate regime where the CT can compensate for those breaths without creating the artifact, which we'll see in just a moment. Some abdominal compression techniques can reduce respiratory related patient motion. The reason for that is we're compressing the patient, and that is a very clinical and nice way of saying we're putting them in a vise and crushing them against the table. It is not overly pleasant for the patient, because we are kind of unnaturally limiting their breath by just essentially compressing their abdomen until they find it difficult to breathe. And so we can keep them from moving in that way, but other types of abdominal compression techniques, particularly things like compression belts and things that are not anchored to other immobilization devices, have been shown to have the opposite effect. Because it is uncomfortable, the patient is more prone to move during delivery. And so not only do we not want to deal with respiratory motion, we really don't want to deal with unknown or random motion during treatment delivery. And so these are all things and challenges that we need to address when we're thinking about using compression. So if we talk about abdominal compression techniques, we can tell from this image, this is a very sanitized advertisement type image. And the way we know that is because, well, one, the patient is not compressed. She very much looks like a human still, and she's smiling. That is not typically the case for most of our compression patients. This is not, oh, this is very comfortable. I enjoy laying on this hard table with this thing smashing me in the abdomen. And so we take these immobilization devices and we put them into these clinical scenarios, and we need to make sure that when we put them into these clinical scenarios that they end up providing the benefit that they're intended to provide, and with as minimal contraindication as we would hope. And what that looks like in my clinic, at least 10 to 15 years ago, looks a little something like this. We would always have a CT order for compression, and physics was required to be at the machine for compression. So physicists would come, and we were largely there to take the heat and say, well, physician would likely use compression, so let's use compression. And we always had very nice, very sweet therapists. They've always been very kind to us as physicists, even us as we're coming out of school and altruistic and not understanding what a disaster we were about to walk into. They were always very, very compliant, say, oh yes, we would love to do compression. But we always knew what they were thinking. This is going to be a dumpster fire because we have to reproduce these setups at the time of treatment. And if they don't line up exactly the way we would expect them to, then we're going to be asked to either re-CT them, or we're going to have to take them down and set them back up. And we were adding a lot of complexity to that setup, at least in the old days before we started thinking critically about how we were doing this type of compression. And so if we think about how it's going in compression and radiation oncology these days, we think of the very early days that you can see here on the left, where we had a bridge that was usually indexed to some really sketchy looking board that the patient had to lay on. Then we just basically cranked this knob until the patient said no more, and we would CT them and hope that that basically restricted as much motion. You can see how unstable this setup could be if it wasn't anchored to the couch. In the upper left-hand corner, you can see compression belts came along, and those were more highly favored for a short period of time before we realized what kind of complications they involve. But they have indexing marks in white where you can set the Velcro, and sometimes it fit the patient, sometimes it didn't fit the patient. If they were really small and frail, it tends to slide down towards their hips. If they were very large and pear-shaped, it kind of slid up towards their armpits, and it's very difficult as you pump them up. We introduced the use of these bridges with vac lock bag systems. So now we're indexing to the table. We're indexing a vac lock bag here on the right. I am not a fan of vac lock bags. That's usually a very highly controversial statement, so we'll wait for the question and answer period to get into that. But these bags also compress themselves. They're not very rigid, and so you can compress inside the bag, but you may be adding some variability with those bags as well. We moved into some more advanced setups or advanced SBRT type rigs as SBRT became more in vogue, I guess, as a course of treatment for many different body sites. And so we see things like the Orfit solution where you have an entire SBRT solution. I believe CQ Medical had one, it still does. A lot of different vendors came out with SBRT specific, and it's going to index the bridges, and it's going to have more simplicity, and we're going to be able to do this. And so we got things like this, and publications came out, and we started looking at things like internal reproducibility and what do these compression schemes actually mean from a clinical treatment planning and treatment delivery process. And some interesting things came out of that as far as, central compression does provide some significant problems from time to time, especially if you're treating a liver tail lesion or something like that. And then you got things like X-Cradle. I have not used this system. It's one of the very few systems I haven't used as a professional, but it has a centralized compression, but you also can use oblique compression. And if you look very closely, you can use lateral compression on the rib cage to keep the rib cage from expanding too much. And so there's a lot of different things that can go on here, but there are limitations. One, these models who are in these photos look to be a little bit younger, a little bit healthier, and a little bit more flexible than most of my patients. And so while I would like to believe that this cradle system would be great in my clinic, I do know that I have a lot of patients that just merely wouldn't fit in that cradle. And so there's things that we have to look at when we're looking at immobilization solutions, and how do we accommodate different body habitus and different challenges throughout the CT simulation process. And then we get into what I call the exotics. And the exotics are things like this publication, and this publication is not to critique the authors. This is not to critique the method. This is not to critique the results. This is just seriously for just a illustrative purpose, some of the things that get published on compression. And what we see here on the left is a wooden base frame with a vac lock bag and a body mask and an air bladder that gets pumped up. And you start thinking like, well, how do I index the air bladder to the body mask? How do I index the body mask to the vac lock bag and the patient, to all of the different devices? You get to the right-hand side, you have the body fix system with a multi-lobular compression cushion that lays across the patient and then gets compressed via vacuum with the cellophane sheet. There's the tried and true, we're going to wrap you in a vac lock bag and just compress you from all directions as best we can and hope this reproduces at the treatment machine. There's this method where we have body fix on the lower half, a wing board on the upper half, and then underneath the body fix cellophane, we have a block that takes the pressure from the paddle, and then the paddle pushes on the block, but there's no indexing of the block to the patient or the block to the paddle. And I'm not really sure how the indexing works between the wing board and the body fix and the hose for the vacuum. And so there's a lot of complexity here. And so these are somewhat challenging setups to reproduce for therapists. It may work great when you have an hour to do a CT sim and nobody else is being CT sim this afternoon. But if you have to fit this into a 15-minute time slot for treatment, this is a lot to do for a therapist. And then there's things like this, which the only thing I can say is why. I tell everyone I have the AIO solution, and I tell everyone I can mask patients from eyes to thighs. I just don't recommend doing it all at once. And so, but some people have other philosophies. And so this looks, I think, like a clarity system here. Don't quote me on that, but this again is an approach for sure. I mean, this will restrict the chest cavity from expanding and the abdominal cavity from expanding. I'm not sure it would be super pleasant for the patient or good for patient satisfaction scores, but we take these methods and we publish them in journals called Reports of Practical Oncology. And when I read these things and I'm thinking practical oncology, I, as a clinician, want to be practical in what I'm asking my therapist to achieve. And so practical oncology to me means something I can reproduce day in and day out and is not going to significantly impact the flow or the likelihood of mistakes at my treatment machines. And so these exotics, while they do work, they do produce results that are worth publishing, they can be challenging for standard clinics to just kind of throw this up and make this a standard part of their practice. So the challenges we've looked at, adding abdominal compression to something requires rethinking your immobilization strategy. You need to think, am I using an in-house solution? Am I using one of these exotics? Am I using a basic solution, or do I have some vendor customized immobilization solution like what we see from Orfit or from Xcradle? Do the patient's body habitus or other conditions prevent us from using something like compression, like a colostomy bag in an unfortunate location, or something that we cannot compress in the region that needs to be compressed? How much compression is needed? How much compression can the patient tolerate? And what is the overall goal of compression in relation to the rest of my immobilization strategy? Do I have to make compromises in my immobilization so that I can use compression? Or can I just simply not use compression because the patient doesn't fit in the device that I have? And so there's a lot of challenges when it comes to adding it just carte blanche to any given setup. There's also challenges related to your treatment planning. So in some devices that you add to your setups can increase your risk for collision during delivery. At our institutions, we do not do coplanar SBRT. We do all non-coplanar SBRT, and that's because publications prove through the 4-pi studies and things like that out of UCLA that multiple approaches to the tumor decreases the spread of dose, which increases the conformality of the dose and allows us to deliver highly conformal variablative doses and come back and retreat organs that you might really not want to retreat from time to time. And so we have SBRTs that are coming in for their 3rd and 4th SBRT treatment. And can we keep those volumes low enough that we reduce the risk of overlap and radiation pneumonitis? And so we think about a DICOM surface like what we see here in green. This is what we CT, but we know in the CT that there's other things on the table. So we can take an optical surface of our patient in their immobilization and in their body mask, and then we can marry those two things together, and we can see, well, there's lots of solution space outside of the CT that I have to be worried about colliding with the machine. And so what we can do is we can put this into one of our collision mapping softwares, and we can actually run through the choreography of a DICOM plan and make sure that we're not going to collide with a patient. Here in the middle, you see the gantry along the vertical axis and the couch along the horizontal axis, and we can see these lines represent arcs of delivery. If we're not in the red regions that map out collisions, then we know we're not going to have a collision with the patient. The problem is if we start adding things to our patients where they're hanging off the sides of the table, we have these very large knobs or very large bridges that have to accommodate larger patients but also have smaller patients in them, we are significantly reducing the solution space. So if we look at the graph below, the gray area is much more confined. We can't even get a single arc all the way around this patient, even at table 0. And the +20, -20 that we'd like to do non-coplanar is actually going to be in a collision area partway through the beam. And we're going to collide with some indexing that's on the side of the table. And so we need to be very careful about how we look at adding these devices, because not only now are we trying to do something to reproduce the patient, but we're now eliminating some of the solutions for better treatments for our patients by adding these devices and these external kind of collision risks outside of our patient's geometry. And so finally, we're looking at reproducibility and efficiency. Going back to this published case, we can see a good example of the previous challenge just in the backlog bag. You can see the extent, how wide the backlog bag and body mask and everything is relative to the patient. On the right-hand side, you can see the irregularity of the patient's outside body contour and how that can change depending on the position of the compression cushion relative to the target. You can see some gapping in the CTs that they've provided here. So if there's gapping and the bag is not tight, how do we know the patient's relative position is the same every day within the bag? And does that impact the amount of compression that they have at the same relative settings for the CT sim? We have to have consistent levels of compression, and that's all going to impact both external reproducibility and internal reproducibility. And again, the more devices and the more things we're adding to our patients are going to impact our efficiency of generating a reproducible setup on a day-to-day treatment. If we look at things like this, again, just highlighting the block again, the block is simply maintained by the cellophane from the body fix system in this case. Its relative position needs to be in the right spot to provide the same level of compression for this individual. And that relative position is relative to the patient, but the patient is relative to the bag, and everything is relative to the bridge with compression paddle that's applying the pressure. So all of those things have to be accounted for and reproduced day in and day out for the proper compression. So we can go to something more simple like this. and try to use something like this. But again, it's not completely free from all of these challenges. If this patient had a colostomy bag right in that area, it's going to be very difficult to just use localized abdominal compression right from the anterior side. And so what we've done is try to address these challenges through a compression masking system with the AIO solution. What you're going to see on the left here is a bunch of images related to how compression masking works, is done in a CT simulation room. I'm going to talk through the text on the right, but basically just kind of walk you through not only what we do, but kind of the mindset of what we should be thinking about as we go through. So when we have a patient who has abdominal compression ordered, the patient is brought into our CT room, and the first thing we have to do is assess the proper mask. Proper mask can be of any size. So Orfit provides, I think, 40 to 60 plus different solutions. Don't quote me on that, to the AIO base plate. So there's lots of different masking solutions. And we want to select the right masking solution at the right size for the patient. So we select the right mask, we place it in an oven, and we allow it to preheat. While it's heating, we prepare 2 to 3 cold wet towels are prepared, and that's helped to cure the mask during the abdominal compression application. And it also is the mechanism by which we apply the pressure to the patient's abdomen. So it's not a localized hard paddle. We're using the towels to apply that pressure to the patient's abdomen. While the mask is being warmed, a therapist is placing the patient on the AIO solution on the CT couch. We're getting them centered. We're also describing the simulation procedure process to them, because they're going to be an active participant in this process with us, and we want them to understand the steps that they'll be asked to achieve during the CT simulation. While we're describing the CT simulation process to them, we're assessing their breathing pattern. So are they breathing rapidly? Are they nervous? Are they cold? What's going on? We're also assessing the mode of their breathing. Are they a belly breather? Are they a chest breather? Are they bimodal? Are they, exhibiting any type of irregular breathing that we need to account for, or that we're trying to compensate for? So just get a general idea of what the goal is here. And then the location of the base of ribs. And so the base of ribs is essentially the best landmark for us for indexing, to making sure they're in the mask appropriately. It's usually one of the most pronounced on most patients. Now you have very large patients that are pretty nondescript throughout their abdomen, but it usually is a good indicator. So we're trying to locate those as well. The superior inferior masking slots are also assessed. So once they're centered on the board, we're looking to see if we need to use the outer slots, if they're larger, smaller slots, if they're thinner. In this case, this patient actually had outer slots near her hips and inner slots near their body, because the goal in using the mask for compression is to keep that mask as close to their body as humanly possible. And so, because it is going to be what's going to be applying the pressure, and the more you have to tent out to the slots, the less compression ability that mask will have. So we want the mask to be very close to the patient in all aspects, even before compression. And so when the mask is ready and we've talked to the patient, we've got them ready, the mask is brought over to the patient on the couch. And you see here in this middle image, we're gently stretching this mask so that we can reach the slots with very little downward pressure. So we're trying to stretch this mask so that it gets a uniform stretch across the whole mask. We don't want to just lay it on the anterior portion of the patient and shove it straight to the slots, because what you get is overstretching of the sides of the mask, which loses some of its compression ability, and you may get asymmetric, because very few times are both therapists in so much sync that one doesn't pull it faster than the other one, and one gets really stretched and one has no stretch to it. And so now you have this asymmetric stretching of the mask, and you can have some uneven pressure during the compression. And so what we're looking for, again, is that uniform abdominal compression for this. Once the mask is properly stretched, the bottom image, we ask the patient to take in a deep breath and then exhale as much as humanly possible, and then hold their breath at the bottom. And we know that this is uncomfortable, especially for patients with lung tumors. So we tell them, we're going to be working very rapidly, but we need you to be able to do this. And if it's a thing where the patient might not be able to do it, we would have them practice before we did this. We wouldn't want to be holding a stretched out mask, waiting for them to see if they could achieve this. So we know they're going to be able to do this. We ask them to do the instructions that we ask them to. So they exhale, hold their breath, and we apply the mask to the predetermined slots from the assessment at the time of when we laid them down on the couch. Once that is attached, one therapist begins to roll the mask, or not roll, but fold the mask down to just below the base of the ribs. Again, looking for the ribs. If they are pronounced and we can see them, we will usually use them as an indexing point. And so we'll try to capture kind of the corners of the base of the ribs. But they are folding it to basically give it more reinforcement. It makes it thicker in that area. And while they're doing that, the second therapist is retrieving the cold wet towels from the storage location. So they've pre-prepared those. We know we need those, and those are going to be what we're using to provide the uniform compression. Once the towels are brought over, and they lay basically it's usually quartered, so it's folded lengthwise in quarters, and then it is draped across the thick part of the mask that we just folded down, and a uniform compression of down, superior, and towards the body. So we're kind of like cradling underneath the ribs and pulling superior. So the goal is to compress in all directions and support the diaphragm as much as possible. Because what we don't want to do is have the diaphragm unevenly supported, because the diaphragm, like with central immobilization compression, if you allow some area for it to move, it's going to move because the patient is going to breathe one way or another. And if you've eliminated one location for the diaphragm to move, it will move side to side, which is poorly correlated to external anatomy. So what we want is still a soup to inf motion of the diaphragm, but very minimal if we can afford it. So we're supporting the diaphragm from all directions. And so we know how much compression we're going to be given based on the CT sim order. There's sometimes we'll have mild compression, some is light compression. We'll have full compression for forced shallow breathing, which is the case for this individual. And so we know how much pressure we need to apply, and it's going to be dictated largely by the body habitus of the patient. If you have a very heavy patient, it's very hard to compress them with full abdominal compression because you're trying to push against a lot of adipose tissue. And so we're trying to apply that pressure, whatever's ordered by the physician. And as we're applying this pressure, we can feel if they're breathing shallow. We've told them at some point you're going to have to breathe, because exhale breath hold is very difficult. When you breathe, we're going to be limiting your breath hold, and we want you to breathe shallow. If for some reason we feel that they're not breathing shallow, additional pressure to the central portion of the abdomen may need to be applied to kind of counteract that from stretching the mask. So in this bottom left-hand corner, we see a therapist placing her hand to kind of push up and in underneath the xiphoid process to kind of give additional support to the diaphragm while they continue to pull uniformly in all directions on the patient. There is a single person method where you typically need a little bit taller therapist or stronger therapist to do this, but you can grab both sides of the towel and you're basically pushing up and in towards the rib cage to continue to cure the mask, but also provide that additional pressure, especially for heavier patients. And then there's other patients where maybe you just feel a little bit of breathing because every other breath they're forgetting to breathe a little shallow. They're trying to kind of extra catch their breath. You can place your hand on their abdomen and let them know, hey, I'm going to be having my hand here just to remind you to continue to breathe shallow. I know it's uncomfortable. And so as we're doing this, there's different ways to add that additional pressure if the patient is resisting the pressure or the uniform pressure from the compression mask. Finally, as we watch the mask cool, we're basically taking time from time to time to peel the cool towels back to see if the mask is cured enough to remove it. So once it's cooled to a point where the translucent appearance is gone, typically this will not be in the area where you've doubled it up or if you folded it down. That tends to hold heat more so than the thinner areas. But if you've folded it down and everywhere else seems to be cooled to a point where it doesn't have that translucent appearance, we will again instruct the patient to breathe out as much as they can and hold their breath, and then we remove the shims and unlock the mask. We remove the mask, and the reason why we do it under expiration breath hold is we don't want them to take a big deep breath from relief and stretch the mask in some way. And so we have them breathe out, we remove the mask, and the patient is instructed while we do the rest of the cooling and the curing of the mask, you can breathe normally. So they lay on the couch in the sim position while we take the mask over to a sink that has extremely cold water. If you don't have that, you can use a bucket of water with ice in it, and we spray the mask down until it's completely cured and cold to the touch. So we're spraying it, removing the heat, trying to further cure the mask and actually promote some shrinkage through crystallization of the aquaplast material. And so once it's completely cool and hardened, we dry off that mask. That mask is dried off completely and kind of let to warm up a little bit because we don't want to put a cold mask back onto our patient who we just had a hot, wet mask on. We then inform the patient that now we're going to do the CT sim. The mask fabrication procedure is over. When we apply this mask, it is going to be much tighter than it was the first time because it is now shrunk a little bit. And so when the patient is ready, we instruct them to, again, take that deep breath in and then exhale completely and hold their breath. And now the hardened mask is reapplied to the patient in a controlled manner. What that means is if we decide to put the mask on, we're going to put the right side slots in first, roll the mask to the left side, and use downward pressure to lock the mask in on the left side, or vice versa, left to right, or even inferior to superior if there's some reason to do that. But what we want to do is make sure that we're noting how the mask went on the patient, because now the mask is in a state that it's going to be in on the day of treatment, and we want the internal anatomy to experience the same application of that mask each day, because we've seen over the years that consistent application means consistent internal anatomy. Our original studies on this were in liver with fiducials, noting that the offset and doing it in a consistent manner was around 3 millimeters between the setup position and the cone beam CT shifted fiducials. Doing this with a central compression paddle was almost 1 centimeter to 15 millimeters of offset in the same instance. And so the consistency of putting this on and off in the same way really adds to the internal consistency of the organs and the landmarks internally when you do a cone beam CT. So after the mask is hardened, it's been applied to the patient, we will ask the patient, are there any pinch points or hot spots? Pinch points, sharp areas, things that are irritating you, things that are hurting you right now. Hot spots, things that are pushing on you really hard in non-compressible points, like the ribs, the pelvis, the iliac crests. On very thin patients, that can be extremely uncomfortable given how much this thing shrinks. And so if they are identified, we mark them, and then we can use a heat gun to loosen those up. I should not have to say this, but I often have to say this. Please do not use heat guns on patients inside of masks. You will burn them. Unfortunately, I did not say this one time in the past, and then I had to hear about someone who tried to do this. Thankfully, the patient stopped them before there was any injury. But please do not apply heat to patients or masks that are on patients. You do that afterwards. But you can easily mark these areas and loosen them up with a heat gun and then reapply the mask to make sure, because they are going to be in this mask for about 10 minutes for treatment, and you don't want them to have pain for that 10 minutes because that's going to cause them to move. After you have the mask on, it's a simple CT simulation. It's free breathing and 4D CT at our institution. And that oftentimes for us, I mean, this entire process usually takes about 20 to 25 minutes to make a compression mask and complete the free breathing and the 4D CT. And then, any exiting instructions to the patient if there's any bowel or bladder prep or anything else we need to do for prostate or something like that. So, but really an easy process, lots of steps to remember, but fairly easy to fabricate and does not take any more than, I mean, if you schedule this in a 30-minute time slot, you're going to be done in 30 minutes without any issue. That being said, what does this buy you? So this is that exact same patient that we saw the images on. On the left-hand side here, this is the 4D CT in 2 different window and levels. And this is to illustrate that there are no artifacts at the interface of the lungs here. There's also no artifact at the level of the tumor here. And then really important for liver SBRT in the tail, you really want to know where the stomach and where the heart is. And this plane that you can see here on the 4D has not been obliterated. If you look at a lot of your 4D CTs, this plane is largely not there and very hard to see. And that is very hard to do SBRT and wanting to have really tight tolerances on cardiac toxicity and stomach toxicity if you can't find the boundaries of those organs because they've been blurred up by your 4D CT. So the quality of this 4D CT is absolutely excellent. You can't hardly see any motion in the 4D CT. You can see that there's a little bit of motion, but we're not going to have to incorporate a ton of healthy tissue. Contrast that with her free breathing CT or free breathing 4D CT, where her irregular breathing and very slow BPM, so this was a 6.5 BPM CT, you can see the interface of the lobes of the lung are blurred, and they're right at the same level as the target. What you also see is this horrible banding artifact because it's just oversampling or undersampling the breath cycles. And so you see, unfortunately for us, a banding artifact right at the level of the tumor. And so this patient was originally 4D CT without proper compression, and the compression, the 4D CT did not look appropriate. They had too slow of the breath per minute. This physician decided she wasn't a candidate for 4D CT and needed to be DIBH. She was simmed as DIBH, planned as DIBH, and after 45 minutes on her first day, could not achieve the deep inspiration breath hold position required for treatment. So that treatment was abandoned. She was sent back to us for SBRT with abdominal compression masking on the AIO solution or 4D CT again. The abdominal compression masking, you can see, allowed us to get 10 breaths per minute, which is the minimum for compensation on our CT, which obviously produced a far superior 4D CT. And the average total treatment time for her across her 5 fractions, she finished this last week, was about 8 minutes. And that's walking in the room to walking out of the room. Total beam on time was something like 2 to 3 minutes. Very, very quick delivery for this SBRT. If you look at her cone beam CTs, again, the target is almost indistinguishable. If you look, you can tell by the poor quality of a cone beam CT. The upper left and the bottom right quadrants of the images in each viewport are cone beam CT. The bottom left and the upper right are the diagnostic or the planning CT. And you can see that the alignment and the target volumes are incredibly tiny and very, very tight, and allowed us to reach all of our tolerances and all of our dose constraints for this patient. So the abdominal masking technique adds a lot of consistency and reproducibility and allows us to treat, instead of 45 minutes to an hour with breath hold for a pulmonary compromised patient, we can come back in and still, with very tight volumes and very tight margins, treat within a 10-minute time slot with no issue. So the advantage of the compression technique, the motion management incorporates both immobilization and respiratory motion considerations into one efficient device, which allows us both breath control and proper patient surface visibility. That's important for us because we use, like I said, SBRT on every single patient. So in the case of the little old man that you see in the images above, you can tell how acute the base of his ribs are, very easy to index to. The compression level is going to be consistent as long as he's in the mask appropriately. The compression in this case was very easy. He's a very finely or frail little old guy, so compressing him was very easy, and the quality of his 4D CT looks like a phantom. He was absolutely an excellent patient, very compliant and very easy to do this on. Now, there are challenges if you have much larger patients. Again, you're going to fight that body habitus a little bit more, but a lot of times this is a very easy situation to handle because you're using the standard immobilization in each instance. It significantly reduces the collision risk for the planning process by conforming to the patient anatomy very closely, expanding the solution space, expanding the gray area available to my dosimetrist to make these non-coplanar, highly conformal treatment delivery plans. And it has a very high degree of reproducibility with proper application techniques. So remembering left to right, right to left, soup to imp, how you're locking this in, the reproducibility, not only from an external reproducibility, but the internal reproducibility is extremely high. And the efficiency, again, we have basically locked in the degree of compression as well as the location of the compression all into one device, and it's the setup device. It's the compression mask itself, and that's locked in at the time of sim. It will not change. There's no settings to record in your setup note. It's simply make sure the patient is indexed to the board correctly and in the mask appropriately. There's no other settings and devices and things that we have to put on the patient, which allows us to treat in these expedited time slots. So, in summary, we've reviewed respiratory motion management in radiation oncology. It remains a significant challenge, especially in the days of increasing use of SBRT throughout the body. We had hopefully a little bit of fun reviewing some of the various compression techniques and devices that are out there in the management of respiratory motion. We introduced the use of our abdominal compression masking technique for controlling respiratory motion here at the AdventHealth Colorado facilities, and have hopefully illustrated some ways that abdominal compression masking can address some of the most common challenges within radiation oncology as it relates to these issues in respiratory motion management. And with that, I will say thank you. Special thanks to the AdventHealth physics team who makes all this stuff possible and makes all these wild ideas work for us. And then also, again, thank you to Orfit for allowing us to share this with everybody.
All right, questions are rolling in, Mike, so we'll get right to it. So first question, are you using compression on liver and pancreas patients as well?
Yes, anything in and around the diaphragm typically will get abdominal compression unless it's a good candidate for DIBH. Because we have SBRT, we favor DIBH if the patient is able to hold their breath consistently, and that's evaluated obviously at the time of SIM. So if they're not a DIBH candidate, they're essentially always getting compression.
Makes sense. Next question. So with the limited motion using the compression mask, where are you placing your RPM box on the patients to get a good 4D scan?
So we don't use RPM and we're not using bellows. Again, we're using SBRT. The product that we have at SIM is called SIMRT. It's an optical patch. So basically it works just like SBRT at the machine if you're familiar with it, but it has a centrally focused camera. It's mapping the 3D surface of the patient, and then we just control left mouse click in the areas where we can see maximum excursion for breath. It's really nice because it's great for expiration breath hold, which RPM and bellows tends to struggle with. But it also doesn't require a lot of surface excursion. So very small motions down to 1 to 2 millimeters can be tracked with the optical system, where that's a little bit harder to track with RPM or bellows or ANSI or one of those other systems. So it makes that possible with that very small motion is the technology that we're using.
Understood. I like this question. Why does Mike not like backpacks?
Oh man, someone's picking a fight. I probably know who this is. I absolutely loathe backlock bags. We do not use them across our sites, and that was one of the first things that I petitioned to remove because of consistency. We've all had backlock bags for prostate patients, for example, that they're getting 28 fractions, and by the end, from getting in and out of that backlock bag, it is just essentially a small wafer that they lay on. Backlock bags are not non-compressible, and so when you're using them specifically in what we're talking about compression schemes here, when you're pushing against the patient who's pushing against the bag and the bag is changing shape, you're changing the level of compression from day to day. And as that bag deforms, it gets worse and worse because what you're getting is more lateral motion. So you're getting less compaction, I guess, from the sides, and that allows the patient to swim underneath the immobilization as well. So for me, I really don't feel they're as reproducible as people would like to believe, and that comes from many, many years of cone beam CTing people in backlock bags. But that is very controversial. I'm very aware of that, and some people continue to use them, and they're very happy with them. They just will never show up as long as I'm alive in one of my centers.
All right, I have kind of a follow-up to that backlog question. So some centers feel differently about back bags, and if they still want to use them, are they able to do this compression technique while still using a backlock, or is that just not recommended at all?
You can, and this technique, actually, I didn't touch on it in the talk. I have helped people develop this technique at their sites on the Orfit solution with the backlock bags that Orfit provides, against, obviously, my better judgment. But what's nice about this technique is if you're using the backlock bags on AIO, the backlock bag and the mask goes around the backlock bag to the slots. And so you actually have some help from the mask for that lateral stability of the bag in the region of the mask. So it actually helps index the bag to the patient as well as indexing the patient to the bag. And so it allows you to kind of better align the patient in the bag because the bag's not deforming underneath the mask because the mask is providing that additional support and preventing it from deforming. So if you had to do this compression technique, you can do it in a bag. It's just a little bit more difficult because trying to get that lateral pressure with that towel and for that mask to cure with the bag in the way, you really don't know how much pressure is actually being applied to the patient. So the best way that I found to do it with the backlock bag on the AIO solution with the Orfit bags was to thin the bag out in that area. So basically have a backlock bag upper and lower, but kind of thin the bag out, or use 2 backlock bags, one upper and one lower, and then bag, or basically apply the compression in between the bags. So if you try to do it over the bag, it's possible, but it can be difficult because the bag, again, is providing more buffer than it is compression because that bag will compress as you suck it in, basically. So as you lose that compression, you're going to see that patient swim underneath the mask a little bit. So it's up to the user, but it can be done. You have to kind of account for some of those indexing and loss of stability of the bag over time.
All right. So I know that you use surface guided, but do you have any recommendations about where to place setup marks for those that aren't necessarily using that and still want to mark for patient?
Yeah, if you're tattooing, if you saw the little old man slide, he had a tattoo in the window of the mask. So these masks have an upper and a lower section typically, and there's like a arch that goes between them. It's great to try to put a landmark there if the patient's anatomy is somewhat stable there, because that also gives you, if you can see the mark in the window, you know that the patient relative to the mask is in a good position. Say you can't find the base of the ribs. That's another good way of making sure that they're lined up. Typically these patients, because you are supporting just under the ribs, there's a lot of chest cavity, so lateral aspects of the ribs, sternal tattoos still work. And again, I've done some consulting in sites that still tattoo and are doing this successfully, or at least were when I was there, by still being able to place tattoos because you have a lot of anatomy. If I have a lot of anatomy to visualize with SGRT, you have a lot of anatomy to choose from for placing your tattoos and your marks. So if you're not using tattoos, you're using like tagoderms with marker marks. You still have a lot of anatomy to do that. And you can also put marks on the mask with tape, like the old school days, mark the mask, mark the patient, and make sure the laser line hits both marks as well. So that's all well within the realm of possibility if you're still using marks.
Absolutely. All right. Next question. Have you used this compression technique with any pediatric patients?
I have not. So we don't do pediatrics here, and this was developed in Colorado. So unfortunately, the last time I did pediatrics was my residency, and this was not available then. So I've not tried it on pediatrics. There's no reason biomechanically why that wouldn't work with pediatrics. They're probably actually much easier to use this technique on, just simply because you don't have a lot of really large obese children. They tend to be a little bit smaller and easier to kind of confine. The AIO solution, though, is very large. When you think about pediatrics, a child will be very small relative to the slots. So getting the compression without that tenting effect is going to be a little bit more difficult because the patient is just marginally size-wise smaller than those slots, because those slots are designed to accommodate adults. So I don't know if Orfit makes anything pediatric specific, but those are the things that come off the top of my head that may be a challenge for pediatrics this way.
Understood. So kind of a broader question, but I'll narrow it down. So what would you say is the more common challenge that is faced with this type of setup, whether it's in sim or on the treatment side?
The most common setup that we have is if a patient is extremely large. If a patient is extremely large, the idea that you're going to be able to compress them goes down exponentially, because you can think if they go beyond the outer slots, you're now putting a mask on the patient, and you kind of have to go underneath the patient and lock the slots in. And then while you're applying compression, you kind of have to navigate what the body habitus is allowing you to do. We have compressed extremely large patients, 400 plus pound patients. We have done that, and with some success. We've had other patients. You think about the old guys who have like a really hard belly or a very large pannus that moves around from day to day. Those can be challenging. So that technique it can be limited by a very challenging body habitus. And then you're largely looking at your 4D CT. And if the patient's a slow breather and has a bad body habitus, which happens rarely, but it can happen, you're looking at a hard treatment. You can go back from our experience in the old days with the bridges, but those patients tend to be challenges with the bridges because of that additional adipose tissue and things that are complicating the mask technique. You find you have the similar complications with the belts not fitting, the compression belts that pump up, the pneumatic ones, and the bridges that apply central compression. It tends to want to move the internal anatomy all over. And so we try to navigate that the best we can. And it's largely sometimes you just have a very challenging patient. So I don't want to put out there that this is the panacea of solutions. It's not a solution for everybody, but it does work. I mean, like I said, 95% of our patients that are not breath hold patients always end up in compression just because of the quality of the 4D CT that it provides.
Perfect. So this question, so some centers, when they're making a mask, sometimes they don't wait for it to cool all the way before they start the scan. Are you recommending that this mask gets fully cured and cooled before you put it back on the patient and scan it?
Yeah, so you can literally hold the cold wet towels there until it's cured enough where it won't stretch, but it is a long time. Because you've folded the mask down, it tends to retain heat because of the two layers together. So you're going to be standing there for 20, 25 minutes trying to cool it with a cool wet towel. If you try to cool the mask the way that I demonstrated in the talk, where you're putting it in cold wet water or cold wet towels and then putting it in a sink and rinsing it with cold water until it's completely cured, you will get shrinkage. That's part of the compression technique. If you are just applying a body mask for immobilization and you don't want a lot of shrinkage, putting it in cold water is going to shrink it. So you have to kind of decide, if I don't want shrinkage, I'm just using it for immobilization. You probably don't want to use cold water. But a good example, if you haven't waited long enough for your body mask to cure and you've done a CT, it's almost instantaneously identifiable at the time of treatment, because you get in there and the patient is breathing underneath the mask and you have a gap between the body and the mask. Because what has happened is you let it cool almost to the point where it wasn't stretching, but it's amazing how strong someone's diaphragm is, and it can actually gently, just slowly as you're doing the CT, stretch that enough that it's really not applying a lot of immobilization or compression. So you do have to make sure that it's as tight and as dry as it does, and that's why we do what we do, because we want to CT them in the mask that they're going to see on every day's treatment. And if it's warm and stretching on the day of CT sim, we have no idea what we're going to see on the treatment days. So we try to make sure that when we sim them, the mask is completely hardened and applied in the same way that we're going to see the completely hardened mask and applied for the treatment days.
Makes perfect sense. So this is a question that I actually get a lot when I'm on site with staff as well. So do you notice any sort of skin or, skin dose reactions with that mask being folded over so many times?
No, so it's usually folded down once. We try not to like I said roll in the talk. I shouldn't have said that. That's why I tried to correct myself. You don't want to roll it down because then you have a real thick band of plastic. There is increased skin dose. We know that from publication with Aquaplast mask. There is attenuation with the mask itself. It is in the treatment plan though, and a lot of SBRTs are being delivered via VMAT or 3D conformal arc or multiple static non-coplanar beams, and so we don't see increased skin dose because we're accounting for that in the planning. If you're not accounting for it, say you had a plan where you didn't have a body mask and then you put a body mask on it, you're obviously going to see a bolusing effect from a mask, but modern treatment planning techniques typically mitigate that to next to nothing. If we can treat on MR guided Linacs where we're shooting through MR coils, we can shoot through a Aquaplast mask without too many problems. So we typically don't see any issues with any of our planning or skin dose, like coming anywhere near skin dose tolerance, even when, some lung tumors, especially in really frail older individuals where the lung tumor can actually be very close to the chest wall and then very close to the skin surface, we typically don't have any issues with those. And so I can't think of one where we've ever had like a skin tolerance issue that we thought we were going to have or anything like that, where we were not completely 100% comfortable shooting through it.
So this question, I see a lot of abdominal lung uses for sure. What about a breath hold with the breast, especially left breast?
Breath hold with breast, we do everything again here, SGRT. So my bias fully admitted in this answer. We do all of our breath hold for breast completely without compression, any body mask, anything. We do it with the SGRT systems. And so if you don't have that and you want to do forced shallow breathing, you can use this technique. And that, you can see on that 4D CT how little she's moving. It would be a good way of doing that. Breast fractions can be 15, 16 fractions. If you're doing the FAST protocol for sure, like partial breast, I think that would be fantastic for that. That's actually a really good idea. I've not really thought about applying this to FAST protocol breasts. But like a 25 fraction breast, that's a lot of compression 25 times in a row. So, if the patient can tolerate it, it's definitely going to minimize the motion of that breast. But it was going to be a much more uncomfortable situation for a patient in a compression mask versus just hold your breath with SGRT or something like that.
So would you ever use this technique for a DIBH setup for a patient?
For a what?
For a breath hold patient.
Like for you doing, had to use it for a breath hold because their breath is really severely limited. So to get a breath where they could hold it for an extended period of time, it would be difficult under compression just because they're breathing so shallowly because of the mask. A lot of times we will favor the compression over deep expiration breath hold because it does kind of force very shallow breathing. But if you're going to do deep inspiration breath hold, the deep part kind of goes away when you have compression. And so if you're going to do breath hold with compression, you're going to probably have very short breath hold durations because if you've done it appropriately, they can't get a very deep breath to begin with.
That makes sense. All right. So this is a comfortability question. So do you have any patients complaining once the mask is hardened that it's too tight, or when they get to treatment that they have issues putting the mask back on?
We will sometimes get patients who will say that's way tighter than I expected at the time of CT Sim. And what we do typically at CT Sim, we'll say, well, this is what the mask is going to feel like each day. Your treatment is going to be roughly 10 to 15 minutes. We try to give ourselves an extra 5. So if it's going to be 10 to 15 minutes, do you think you can be in the mask for about 10 minutes? And if they say, I don't really know if I could tolerate it, say, can we put you in the mask and see if you can tolerate it while laying on the couch here? Because if you don't want it on, we can just pop it off. If they were to say, this is absolutely not tolerable for me, you can again take the heat gun, and what you do is you heat along the brackets that go into the AIO, and that allows you to apply a little bit of stretch. This is where you don't want to do that with the patient in it. It's almost like a great idea to heat it up and just let the patient kind of stretch it themselves. But you're going to melt the cushions. 2, you're going to burn the patient. Please don't do this ever. Warning, 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 big red letters. But you can heat along those L brackets. And put it back on the patient after they've been heated up and kind of let that expand, and you can slowly get them to a point where it's tolerable. What usually ends up happening is it's, when I talked about hotspots, it's pushing on the corners of their ribs, and they're like, I cannot tolerate this. So we'll mark those and we'll loosen those up. And typically it's not the compression on the fleshy portion of the abdomen, it's the hotspots on the apex of their iliac crests, or on the base, the corners of the anterior portion of their ribs. If you've got a lot of pressure there, it's really, really uncomfortable. And to lay there for 10 minutes with those things is somewhat uncomfortable. So usually what we get is it's too tight, and then when we start digging into where is it too tight, it's usually on those bony landmarks. That's why we would probably expand that without releasing the compression, and hopefully get a happy medium that they can tolerate, basically.
Perfect. All right, we only have time for a few more questions, so I apologize if I do not get to yours, but we'll see if we can squeeze a few more in here. One question: do you know the thickness of the mask that you use? And I can find out.
I'm sure my therapist do. I'm thinking it's a 2 mil, or not a 2 mil.
I think it's a 3.2 millimeter mask is the one that's
okay.
mask. Yeah.
Yeah, so I can't remember, because I know we have some that are thicker, and then we have some thin masks, but I don't remember which. Some are head and neck, some are pelvis, and so I wouldn't go off of mine. I would go off of a much more close to the ordering side person to get that information. But if it's important, they can give you my contact information. I'll reach out to my therapist and find out what that thickness is.
Perfect. All right, another question. So if the mask is not fitting, so let's say you do your sim, patient comes back for treatment, and your mask seems to just not fit for whatever reason, what is kind of the course of action at that point?
Well, we try to put the mask on. We have had minimal, and when I say minimal, 1 to 2 cases that come to mind right now over the last 10 years where the patient had severe ascites of the liver and lots of fluid. And so there was no way that mask was going on that patient comfortably. And so if that happens, that's an indication that there was a drastic change in the patient's anatomy from the time of sim to the time of delivery, which usually would indicate that there might be some planning indications to that as well. So if we had a mask that we're like, this is not going on, one, we're going to check, did we grab the right mask? Is this the right human that we're trying to put this mask on? They have their names on them, but it could be the fact that, maybe it's not the right mask. That's usually, I grabbed the wrong person. I grabbed Mrs. Smith instead of Mr. Smith, and Mrs. Smith's mask is not going on Mr. Smith. So that usually human error. But if it's truly a change in the anatomy to the point where it's just not going on, or they've decided, I'm not tolerating this today, we obviously wouldn't force the patient into it, but we might CT the patient or have them see the doctor and be like, we think there's a significant change in their anatomy. And so that would be a clinical assessment at that point, and probably a resim and a replan at that point, if it was truly an anatomical reason why they wouldn't fit in the mask. But usually if it doesn't fit, we've used the wrong pad underneath them, it's the wrong person's mask, we grabbed the wrong thing, something like that, and then it's easily identifiable. But I can say, in those 2 instances, there was a significant amount of ascites, and that they had to have fluid drained off their liver. We brought them back, tried to put the mask on after the fluid was drained, still didn't work. And I'm like, we're not forcing this. We're going to just resim and make sure that the underlying medical condition is addressed before we try to just force the issue.
Right. Sometimes there's really no other option than go that route. Let's make this the last question. So for therapists maybe trying this technique, for the first time, do you have any specific tips and tricks that they should focus on, or things to really think about while they're making this type of mask?
All of my tips and tricks are in that text. So if they get the text of this or the screen captures of it, the things are thinking ahead of time. So explaining to the patient is very important. So getting the patient laid down on the thing, selecting the proper size mask, explaining what we're about to do, because we're going to be asking you to exhale and hold your breath, which is not comfortable typically for lung patients. Liver patients, it's usually not an issue. But again, explaining that sim process, what they're going to be asked to do, what they're going to feel, what we're going to be saying, and what you'll see us do, that's all really important for success. Just going in and thinking you're going to lay someone down and I'm just going to wrangle you with a towel and it's going to work, it's probably not going to work. So that forethought and that assessment period is really important at the beginning. And then just making sure that you maintain that pressure, because anytime you let off that pressure, these masks are flexible, they're going to stretch. And if you have a compression mask that has a gap at the time of treatment, it's not an effective device. So you really need to bail on that. So making sure that you do the steps in the order, making sure you have that pre-assessment is really important. And you'll most likely be successful. I always tell everyone, you're going to introduce a new technique, find some volunteers, find some residents, find somebody and put them on the couch and try it a few times, because you're not going to be good at it at the beginning. We took a while to get this technique kind of down to a point where we could get it to a science.
I agree with that. So with that, Mike, I just want to thank you for your participation today. Very much appreciated, very informative. And again, I apologize if I didn't get to everyone's questions, but we are starting to run out of time. So again, Mike, thanks for joining us. And